Alrighty, hello everyone. Welcome to Grand Rounds. Nice to see everyone's faces so bright and early in the morning. Today we have two great speakers. First up is Dr. Antara Dattagupta, who earned her Bachelor of Science in Chemical Engineering from Texas A&M University. She then went on to get her MD and Master's of Engineering at the Texas A&M Health Center of Medicine before coming here to St. Louis at WashU for her internal medicine residency. As part of the global health pathway, she has combined strong clinical skills with a broad perspective on healthcare delivery. Now in her PGY 3 year, she is preparing for a career in rheumatology. Let us welcome Dr. Antara Dattagupta to the podium.
Thank you, everyone. Right, testing. I'm sorry. All right, can you hear me? Yep. All right, so my project is the price of relief, examining the role of insurance in high-cost medication use. My mentor is Dr. Diffie. So before we begin, I'm going to actually start with an exercise with you guys. So raise your hand if you have tried to prescribe a patient a medication only to find it was rejected by insurance. Okay, look around, it's almost everybody. And then one more really quick question is, raise your hand if you've had to submit a prior authorization or call insurance to appeal with a peer-to-peer. So this is pretty much something that everyone is facing. So in an ideal world, us as physicians and the patients, we discuss treatment, the next steps, and we would prescribe a medication for them. But more days than not, insurance says, not yet. We would like it to be in this linear fashion of patients needing the medication and then receiving the medication. But it's more like this. And we see a lot of these things that go on. And this causes patients to have delay in treatment and also overall frustration in the healthcare system. This is applicable to all fields of medicine, but I have a specific interest in rheumatology where the ongoing medication therapies in its field are currently expanding at a rapid rate. However, the access to these medications for patients, unfortunately, are not. Additionally, being in the global health track, I specifically focus on the local St. Louis population because health equity and disparities are not just around the world, they're also right here in our city. So here's a roadmap of the discussion this morning. So a little bit of background of the disease in question. So rheumatoid arthritis is a chronic disabling disease characterized by joint inflammation that can lead to progressive damage and systemic complications. Current guidelines recommend a treat to target with the goal of clinical remission. Ways to assess disease management and remission are through inflammatory labs, progression of x-rays, erosions on x-rays, and also the RAPID-3, which is a patient-reported outcome that we'll touch a little bit more on in the later slides. So going a little bit more into the treatment of RA, we see that the first line is conventional synthetic DMARDs, and usually a short course of glucocorticoids that we give. Then it's recommended progressing to JAK inhibitors or TNF inhibitors, which are oral and also injectables. And then afterwards, we would go to infusions for refractory or third line medications, and also like IL-6 and T-cell co-stimulation modulators. So as we can see, kind of lining up what we discussed in the last slide, these are our first line medications that are oral, and as you can see, they're still have a cost per month, but they're not as expensive as going into the JAK inhibitors and the injectables. And then this is rituximab, and just the medication alone is $10,000 to $13,000, but we don't factor into the facility fees and the infusion costs that come with rituximab infusions, and that can add on another $40,000 to $100,000 per patient. And each patient for rheumatoid arthritis needs at least 4 of these infusions a year. So the costs really do add up. So the 4 insurances that we're all kind of a little bit familiar with is our basic commercial or private insurance. So patients who have these have a little bit more formulary flexibility, and they also are allowed to alleviate their copay costs with copay assistant cards from the companies itself. And there's also patient assistant programs, and they usually have faster access to injectables and oral medications. Going into government insurance, and that would be Medicare, Medicare Plus with supplementary and Medicaid, unfortunately none of those qualify for copay cards because of the anti-kickback statute. And because of this, Medicare Part B actually covers infusions, whereas Medicare Part D and that coverage gap would have been ideally covering the oral and injectable medications. And despite all of this, patients still have a high out-of-pocket cost. Medicare Plus is supplemental, like secondary. You can have Blue Cross Blue Shield or another private insurance. So patients tend to have a little bit more formulary flexibility, but they still have the high out-of-pocket costs. And the last one is Medicaid, and as we know, Medicaid has very restrictive qualifications for patients with the lowest income, and they have restrictive formularies, and also for each state it varies. You can look it up online that they have preferences of what Medicaid would cover state by state for insurance, first line and second line. So the overall problem that we're thinking is that structural disparities in our healthcare system limit access to medications for vulnerable populations, and this could cause inequities in disease outcomes. Our current research gaps in rheumatology and medicine in general are kind of seeing real world data on how insurance influences medication access. And there's an unclear relationship of insurance type and disease control metrics as well, specifically in the field of rheumatology. So our initial hypothesis is that we think that patients with commercial or private insurance are likely to be prescribed more biologics or JAK inhibitors compared to government insurance. And why that matters is because these patients would demonstrate better patient-reported outcomes as measured by rapid 3 scores, the erosions on x-rays, and lower inflammatory markers. So our study design and methodology, it was a retrospective observational overview of patients who have comprehensive chart review, and we were done at WashU, and it was the patients who are currently established at WashU. They had a confirmed RA diagnosis, and it was greater than 2 years of care and 3 visits. So briefly, before we did our project, we did an a priori power computation that determined a total sample size of 466 to have an 86% statistical power at a 0.05 alpha to detect a minimum of 15% biologic use between insurance groups using a two-tailed chi-square test that assumed 35% of the sample would be commercially insured and assumed 65% of the sample would be government insured, of which 42% of the government insured would be using biologic medications. So using Slicer Dicer, we created a RA cohort of patients who are currently established and seeking treatment at WashU Rheumatology. These are the data collection parameters that we gathered from chart review. And a few of the specific data collection I was just going to go through. So the first one is the Alex-Hauser Comorbidity Index. So patients with RA, they don't just have RA, they might have other comorbidities. So we wanted to make sure we factor the comorbidities into play and adjust all of our statistical outcomes after the ECI was incorporated. So this is kind of the list of the comorbidities that that can come into factor, and you are able to calculate per each patient what their ECI would be. And this assesses the patient's overall disease burden by quantifying the presence of their various comorbidities. The rapid 3 that we discussed a little bit earlier is a patient-reported outcome that we see in rheumatology. And this is kind of the questionnaire that they get at their visit. And this helps allow a patient to be able to reflect their own perception of their health at that time. And this correlates with other disease activity as well, and they're able to kind of talk about their global assessment of health. And lastly, we wanted to make sure we factored in for the area deprivation index. And this ranks neighborhoods by socioeconomic disadvantage. It factors in income, education, employment, and housing quality. As we see right here in the scale, the blue is the least disadvantaged, and then the red is the most disadvantaged. And why this is pertinent to us is because we are right here right now. Sitting here in Clopton, this is WashU. And right above us is the historic Del Mar Divide. So as we know, there is our patient population, there is significant disadvantage and high socioeconomic disadvantages in these patients. And unfortunately, these are the ones that get the most harmed by insurance disparities and medication access the most. Our data analysis was done by WashU Biostats. A big shout out to Karen Steger-May for her time and effort using SAS software. So kind of going into the data that we collected. So of the 466 patients, 79% of them were female and 21% were male. Of the 79% females and 21% males, a majority were Caucasian, and this kind of in the US distribution, most of our patients with RA tend to be females over males and also of Caucasian descent. Sample data for the insurance-wise, 63% were government insurance and 37% were private insurance. Of the government insurance, we broke it into the subsector for sub-analysis, Medicaid, Medicare, and Medicare Plus. So just from our raw data, we already saw that there was approximately 10% more of government insurance using infusions compared to private insurance, whereas commercial insurance or private insurance used approximately 15% more injectables and JAK-Is compared to government insurance. The percentage of non-biologics were about comparable in the raw data. Additionally, just wanted to make sure we note that we saw a 10% increase of non-biologic use compared to biologic use, and specifically Medicare patients compared to commercial patients. However, this was found to not be statistically significant with a p-value of 0.11. So breaking the government up into insurance into the subsections, we see that over 10% of Medicare Plus patients had used more infusions compared to commercial insurance, whereas compared to Medicare and Medicare Plus, we had commercial insurance use 20% more injectables and JAK-Is. So after adjusting for ADI and ECI, we found that patients with government insurance were less than half as likely to receive injectables and JAK-Is compared to patients with commercial insurance. And breaking it into a sub-analysis by each insurance, we saw that patients with the likelihood of using infusions versus injectables is 3 times higher for patients with Medicare compared to commercial insurance, and the likelihood of using infusions versus injectables is 5 times higher for patients with Medicare Plus compared to commercial insurance. There was no statistical significance for the rate of infusions versus injectables in Medicaid patients. And the likelihood of, these two having 3 times as much and 5 times as much, most likely is what we discussed earlier about the Medicare Part B covering. So most likely they're getting this overutilizations of infusions, whereas we would like them to be on JAK inhibitors or injectables prior to it. So moving to the patient-reported outcomes for our secondary analysis, we saw that just from the raw RAPID-3 data, that patients with commercial insurance had about a 10% remission rate, more remission rate compared to patients with government insurance. So patients in the RAPID-3 goes from 3 or less, and that's their score of remission. The low is 3.1 to 6, moderate is 6.1 to 2, and then high is 12.1. And as you can see, over 10% of patients who had commercial insurance had more remission rates compared to government insurance, whereas government insurance had 10% more of patients in the high range compared to commercial insurance. And when we break it up into the different types of insurance, we also see that there was 10% more remission in government insurance compared to Medicare and Medicare Plus. And then when we compared to Medicaid, it was almost 20% more. And so after adjusting for ADI and ECI, there was a notable difference in RAPID-3 outcomes based on insurance status. Notably, RAPID-3 scores were 1.9 points worse for patients with government insurance. They were also found to have 2 times more likelihood of being in a worse RAPID-3 category compared to patients with commercial insurance. And specifically for Medicaid patients, there was an even higher chance of a worse rapid 3 category. ESR rates were twice as high for patients with government insurance. Of note, when we were evaluating for the presence of erosions, they were not statistically significant, but a possibility for this is because it was like a rare outcome, it was likely underpowered in our study. Notable limitations to account for in our project is that it's a single center cohort at one point in time. Unfortunately, that means that there's limited generalizability for other states. That's specifically because Medicaid state by state picks what medications it will cover. And the study and the data collected from this retrospective observational chart review study is limited to what we see in provider documentations at that capture visit. Unfortunately, we're also unable to account for uninsured patients because we don't see them at the CAM. And then we're also unable to account for certain biases, which are provider prescribing preferences when it comes to medications. So overall, our study shows that there are significant differences in prescribing practices for rheumatoid arthritis influenced by insurance. Patients with any government insurance were 3 times more likely to be on an infusion rather than an injectable or JAK-I. These differences unfortunately suggested worse patient-reported outcomes, noted by having around 1.9 points worse in rapid 3 scores with any government insurance. And then most notable, patients with any government insurance were twice as likely to be in a worse rapid 3 category compared to commercial insurance patients. So we did this project. What now? Where would we go? So things to think about is, can we confirm these results with a large multi-centered data study? And what policies as providers should we advocate for our patients? Can we even consider tackling the anti-kickback statute, which is a big culprit for a lot of our patients? And lastly, how would we create algorithms to identify these vulnerable patient populations in order to stay proactive for them? I'd like to quickly take a moment to acknowledge a few people here today to which this project would not be possible. Thank you to my mentor, Dr. Diffie, for his support and guidance throughout this project. And thank you to Karen Steger-May for her time to analyze all of our data. And thank you for MIMS, for which the project funding would not be possible. And then a special shout out to everyone on the list here as well, to which the project would not be possible. And then now I'll open the floor for any questions before passing it on to Ernan. And here are my references. Thank you.
That's a great talk. Thanks so much. We have time for a few questions. I'll start. So thanks so much for giving that talk. So if you could recommend one fix that you think would improve equity and access for patients in the different payer categories, what would it be? I mean, what do you think we should be doing to be more fair?
Of course, like policy data, I think policy and like regulations would be, the bigger aspect, but, certain things to kind of make sure us as physicians to keep in mind is, if we're trying to start a patient on this medication and we think that there might be a delay, to be able to initiate the prior authorization ahead of time, or to be able to see that there are certain gaps in their care so that we can quickly be more proactive and get them any medication that they could start on. Because the longer they're without a medication, the more likely they'll be able to have an RA flare or it would be untreated for a while. So things that we kind of talked about is creating algorithms to see time to treat, and then also artificial intelligence is booming now. So if there's an AI algorithm to be able to see patients who are more vulnerable and then make sure that there's proactivity in that area.
That's great. So you might be able to develop standardized order sets that would accommodate for their insurance status so that they got into the right pathway right away. You should probably talk to Dr. Karen Joint-Maddox in cardiology, because she does health policy, health outcomes research, has access to large Medicare data sets that you could use for a bigger patient population, and also you could use Express Scripts and Centene data, which is based here in St. Louis, to look at large pharmacoepidemiology for insured versus Medicare or government payers. And there's also a way to look at Centene data, which is available through the Brown School of Social Work and the School of Public Health, to look at Medicaid in Missouri as well. Any other questions?
I guess great talk, by the way. The differences you're seeing in outcomes, sort of remission scores and stuff like that, do you think that's a result of process issues? You mentioned prior authorization, so difficulties dealing with like public insurance versus like a pharmacological difference with the differences that you saw in the amount of different types of medications people are getting for their RA?
For sure. I think it's a mix of both. So I think patients who are delayed to access to medications, that factors in. But also there have been studies that show that JAK-Is and injectables have a faster treatment, like time to remission rate compared to infusions. So patients that have access to these medications, their symptoms are able to get a little bit controlled faster. And so that could also be playing into a factor why their rapid-3 scores are better than patients who have to go to infusion next. And infusions have their own issues as well. Patients' compliance, people who have driving barriers, infusion reactions, needle phobia. So a lot of these patients may not even be consistent on their rituximab infusions, whereas people can easily take an oral JAK-I inhibitor or inject like people do for GLP-1s. They're able to inject themselves as well. So I think both of those really play into a factor of these scores.
Did you have enough data, I guess, to be able to potentially investigate that with a subgroup analysis when you look at people who were on the oral or the injectable, who were on government insurance, who were on private insurance, and what their
So we, I may be misinterpreting this, but we did have that category of infusions versus injectables for government and commercial, and then we broke it into a sub-analysis. Whereas we didn't go into did they get an infusion denied and then go to injectable? That part we didn't go into.
Maybe I missed it. Did you show the remission scores for a person on government insurance who had an injectable versus the remission scores if you were on private insurance?
Yes.
Okay.
Yes.
And those were different?
They had so patients with Medicaid had 20% less remission in the rapid-3 compared to government insurance. And then when you for just infusions versus injectables. So they're kind of lumped on if they were in infusions or if they were on injectables or JAK-Is. That.
Yeah.
Okay.
Other questions? The other thing you could look at some point if you want, because I think in the whole world of sort of drug reimbursement and what the drug prices are and who pays for what and who makes money and who loses money off drug pricing and drug utilization relates to the 340B pricing, which certain patients are eligible for, and then the sort of the cost of acquisition of the drug and then the cost of reimbursement. So there are some drugs that hospitals make money off of in certain settings, outpatient settings versus inpatient settings. So that might be another driver of what gets approved and what people use, because it's incredibly complicated and not always patient-centered, for sure. Any other questions?
One quick question. That's a great presentation. How many of the differences in remission and outcomes that you measured were mediated by differences in disease severity at baseline between government versus commercial? Maybe you had that up there, maybe I missed it, but did you account for that?
We accounted for the, not the disease severity as much as we accounted for the comorbidities that patients may have. And so we were able to adjust everything for Alex-Hauser comorbidity index. The erosions, the rate of erosions at the capture visit were also there, but they were not significant. And most likely it was because it was an underpower, because it was, a rare outcome from that. At that point of time, the disease severity of each patient, we did not assess, but we factored in their comorbidities.
Any other questions? If not, that was terrific.